days when 1930s and 31, when eminent professors of cardiology like Paul Dudley White, he was considered to be the father of cardiology, or American cardiology. And he said, hypertension is a compensatory mechanism. We don't need to tamper with it. Another guy called, I think John Hay or somebody from Liverpool University said that the major problem with hypertension is on one day, some fool will find it out and he will start treating it. So those were the days, no? But now we know it is the commonest risk factor among the vascular disease, causing almost the reason for about 40% of deaths worldwide. And measuring it adequately, controlling it is absolutely important. Whoever you are, whether you are in any branch of medicine, hypertension, as I said, is the commonest disease that you face. So let us start with, I don't need to introduce my erudite panel, it has been already done. And let us start with Sibu. Sibu, let us hear from you the importance of measurement of blood pressure.
If you consider the different risk factors for like diabetes, various risk factors, hypertension measurement is actually, it is very important because there are so many variations, and if you do not do it correctly, the BP can be very high. So it is very important that you do it correctly. There are different methods to do the blood pressure measurement. It can be in the office. It's called manual office measurement, or it can be automated office measurement. It can be home BP measurement. It can be ambulatory BP measurement. Different measures are there. But basically for treatment, it is the office BP measurement which is taken. The guidelines take the office BP measurement. Okay. But then it is very important that you measure the BP properly. The patient should not be in a hurried manner, should not check the BP in a hurried manner. Patient should not take coffee or alcohol, or should not take smoke, should not smoke for 30 minutes. Should be resting for at least 5 minutes prior to the checking of BP. And the patient should not talk at the time when we are checking the BP. The patient as well as the person who is checking the BP should not talk to the patient. Very often we forget that and we ask history, we ask about the patient's details, they fill up the forms, all those things, and at the same time check the BP simultaneously. This is going to affect the patient's BP. Both arms, in the first measurement, both arms should be used. The right arm as well as the left arm BP should be checked, and the higher BP should be taken as the patient's BP. And subsequent measurements can be done on the arm which was showing a higher BP. And a properly validated equipment should be used with a proper cuff size, usually around 12 to 13 centimeters wide and around 26 to 30 centimeters long, covering around 80% of the arm circumference. So the BP apparatus should be validated, and patient should be sitting in a proper manner with a back support, the feet on the ground, legs not crossed, and arm also supported at the level of the heart. So patient should be seated properly, and at least for 5 minutes. That is the recommendation. And then check the BP. And then when we are checking initially, check the BP 3 times. First check, then do 2 more measurements, and at least 1 minute interval, and take the average of last measurement. So if you look at this, checking a BP takes around a lot of time. So where is the time? The patients are always busy, the doctors are busy, the OP is very busy. So very often this does not happen. Very often the measurement is also not validated. You are not using the BP apparatus with the validated BP apparatus. So are we really getting a BP which is a real measurement of the patient's status? So that we should look into. Otherwise, there is no point in treating. Otherwise, there is no point in hiking the drugs. So the problem of not checking the BP properly is that patients can get unnecessary treatment sometimes, and patient may not get a proper treatment. So it is shown that around 50% of the diagnosis and BP treatment can be wrong. Various studies have shown that it can be wrong. So unless you check it properly, patients' BP drugs may go up, patient may get unnecessary treatment.
Because as he said, about 35 to 80% of the time, the office blood pressure has been found to be erroneous. So, but if you take it correctly and with all the specification that Shibu mentioned, and the proper instrument also is, the importance of that, I don't need to stress it, because now the days of mercury manometers are gone. The gold standard of blood pressure measurement right now is one of those digital instruments, which has been validated every time. Shibu mentioned about the office blood pressure, which all of us measure, but we should also note there is something called BP variability. There could be a morning surge of blood pressure, sometimes a nighttime surge of blood pressure, and the variability is equally important like the elevated blood pressure. So the concept of a 24-hour blood pressure reading came into the picture sometime in early 2000. And because it has been found that the nocturnal blood pressure is absolutely important. Generally, our blood pressure comes down, called the dipping. So the importance of 24-hour blood pressure management led on to the ambulatory blood pressure monitoring. And I will request Uni to talk about the importance of Abpm, ambulatory blood pressure monitoring.
Thank you, Mohan. Now, as Mohan said, the BP is blood pressure is a very labile parameter. It varies from day to day. It varies from winter to summer. It varies from morning to evening. And we know it even varies from inspiration to expiration. During inspiration, there is a fall in BP, and during expiration, there is a rise in BP. So when you take just a office blood pressure and start treating a patient, it is almost like taking a frozen shot of a horse race and then commenting about that horse race. It is not possible unless you have a whole video of the horse race. If you are just shown a frozen shot of the horse race and you start commenting about horse race, it will be nonsense. So actually, theoretically, if you take one blood pressure in the office and say my blood pressure is this or that, that does not give you the true picture. That is the importance of 24-hour blood pressure measurement or ambulatory blood pressure measurement. Of course, the most important, as you know, is the masked hypertension and white coat hypertension. White coat hypertension, as the name implies, is when somebody with a white coat takes the blood pressure goes up because of some amount of anxiety. So when you take blood pressure in the ambulatory blood pressure mode, you can see that the BP is high in the office, but it is normal at home. Majority of the time, it is normal. And the opposite is masked hypertension, where when the patient takes BP, when the doctor takes the BP in the clinic, it is normal, but at home, it is very high. That is more dangerous because you don't detect it. And the masked hypertension, the prognosis is as bad as sustained hypertension. So these two things can be detected by an ambulatory blood pressure monitoring. But as you know, this can also be detected by a home blood pressure monitoring. If you have a blood pressure monitor at home, you can take it in the morning, evening, and then you can find out both masked hypertension and white coat hypertension also. But as Mohan said, there are trials which show, there are studies which show that between all blood pressures, average blood pressure, daytime blood pressure, morning blood pressure, night blood pressure, the one reading that correlates best with cardiovascular events is the nocturnal blood pressure. So the nocturnal blood pressure can be detected only when you have an ambulatory blood pressure monitoring. As Sibu said in the beginning, when you take the blood pressure routinely, also the patient has to rest. He does not smoke or take alcohol, does not take food. So what we actually want is the basic blood pressure. So what we actually want is the baseline blood pressure. And that is what you get in the middle of the night when you are sleeping. That you get only with an ambulatory blood pressure monitoring. And the next important thing after the nocturnal blood pressure is most of the strokes, most of the myocardial infarction even occurs during early morning when the time of the fight or flight response is there. You are sleeping and in the morning you are getting ready for the day. The sympathetic activity is high, the RAS system is activated, and so there is an early morning surge. And that is the cause of people going to sleep without any problem. Morning when he gets up, his right arm and right lower limb is not moving. That is, he has developed a stroke. So this also you can detect by an ambulatory blood pressure monitoring. Nocturnal dip, as even in a non-hypertensive, it is said that if there is no nocturnal dip, he is at a higher risk than somebody who has a nocturnal dip. There to be about 10 to 20% fall in the night as you sleep for the blood pressure. Then, of course, work time BP. People who are very anxious, work time BP also you can find out from the ambulatory blood pressure monitoring. And when you do the ambulatory blood pressure monitoring also, during the beginning, when you connect the machine, and at the end, when you disconnect the machine, you have so-called white coat window. Those times the blood pressure will be high because again, the patient is anxious. So when you read the ambulatory blood pressure monitoring, the beginning and the end has to be discarded because they are the white coat windows. Of course, the problem is that you are not very comfortable. It goes on inflating the cuff in the middle of your sleep. So it is not very comfortable. That is one problem. But now we have machines which is connected to a radial artery so that there is no frequent power releasing and inflating the cuff. So more comfortable machines are coming, but as at present, it is not very comfortable. Then, of course, another important use is to find out the 24-hour efficacy of medications. You give a medicine and then you see when the blood pressure is rising so that you can adjust the dose of these medications. Finally, I will give the values and stop. The 24-hour average BP, the current recommendation is should be less than 130/80. That is the average 24-hour BP. The daytime BP, when you are up and about, can be a little high. It is 135/85. But look at this value, that is the nighttime BP. It is 120/70. Anything more than 120/70 is considered hypertension. So that value you can get only by an ambulatory blood pressure monitor. So I think that is what I have to say about ambulatory blood pressure monitoring.
Thank you, Ni. I mean, I'm sure many of you would have used this ambulatory blood pressure monitoring. Now it is available in most of the hospitals and many agencies are available. Some of these pharma companies give you this Abpm without even any charge. So try to, because every guideline, and there is no dearth of it, mind you. There are tons and tons of guidelines. I know he's going to talk about it. So every guideline is insisting that, see, the diagnosis of hypertension should not be absolutely based on your office blood pressure. Ideally, you should be doing a 24-hour blood pressure and then commence your treatment. But then that is, even in the United States of America, the use of Abpm is dismally low. Not to speak of India. So, but this is something which is coming in a bigger way. So try to use Abpm more often. And so office blood pressure, Abpm, and the third important measurement is the home blood pressure, which is much more simpler now. COVID has made us to use, I think every person has a oximeter now. So possibly every person has a blood pressure pattern. So what about Giver, about the importance of home blood pressure monitoring?
The limitations of office blood pressure and also the Abpm, even though it is very ideal, and Dr. as Unmi said, it is useful in many situations. It is rather expensive, not easily available, and it cannot be done repeatedly. But one thing which is increasingly becoming popular because of the decreasing price of the home BP digital monitors is the availability, and people are more and more resorting to home blood pressure monitoring, which actually do away with the problems of office blood pressure measurement. And probably you get the results, even though you don't get the nocturnal blood pressure value, you can get a similar to the mean daytime ambulatory blood pressure value. So that is very useful. And the problem in home BP monitoring is because you can be very relaxed and people may not take the measurement properly. As Dr. Sibu said, you have to do the BP measurement in a proper environment setting, which he has already explained. At home, you are likely to talk to people, you are likely to sit in a sofa, or you are keeping not the arm at the heart level. All this criteria has to be satisfied if you need to get a proper, a correct home blood pressure value. So if you can do that, if you can do a proper measurement of home blood pressure value, adhering to all the criteria which Dr. Sibu Matthew has already told you, then I think it's extremely valuable tool. Now, what I recommend to my patients is to take a 7-day average. Now, the advantage of home BP monitoring is you can take the blood pressure every 1 minute very easily by just pressing a button. So I ask the patients to take for 7 days, 3 readings in the morning, 3 readings in the afternoon, and continuously for the next 7 days. Of the 3 readings, the interval between the readings should be 1 minute apart. And it is always better to discard the first reading and take the average of second and third. And then you average all the 28 readings you get, all the, the 2 readings in the morning, 2 readings in the afternoon, you get 28 readings. And this, from these 28 readings, you get an average value. And this average value, people have found, closely mimic what you can achieve with the mean daytime blood pressure achieved by the ambulatory blood pressure monitoring. So you do away with all the shortcomings of office blood pressure measurement. You do away with the problem of getting an ambulatory blood pressure monitoring because it's expensive, and you get a correct picture at home, provided with all, this is important, provided you stick to all the guidelines. You stick to the all the criteria which are laid down by Dr. Sibu. You should be, the arm should be the heart level. You should be sitting straight. The arm should be kept on the top of your dining table, and the blood pressure, you should not speak. You should not be free from, should not be taking alcohol or coffee or tea. And then take measurement, discard the first one, second and third, 1 minute interval. I think you will get the correct value. So increasingly, this is becoming a very, very popular, and it has been already incorporated into many of the guidelines. And I think many of our patients, but when a patient asks you whether it is all right to use a home BP monitoring, strongly recommend it, but tell them that you have to take it with all the precautions. Now, how do you validate the home BP? That is an increasing question, because a lot of machines are available. How do you get it? Sibu has told about validation, but I don't think that there is no validation system available. No mechanic, you take the BP monitor and say whether this is true or not. The best way is to ask the patient to bring the BP monitor to your clinic and check the blood pressure with your instrument, and then with the patient's BP monitor. And then if the both values are identical, that is the only way which I have found which is useful. Thank you.
Thank you, Gilbert. You must be wondering why are we talking about this measurement business so extensively. This is for your information. Every 3 year or 4 year, or our societies come out with a 25-30 page document on importance of measuring blood pressure. So the measuring blood pressure, that's why even the theme stresses on the importance of. As Gilbert said, home blood pressure measurement is becoming increasingly popular. And when you have a comparative study of Abpm, home, office, Abpm scores, definitely, because it gives us the best results. But it has its problems like availability, cost. The office versus home, here again, the sensitivity is much better with the home blood pressure measurement, even though the specificity is a little less than the office blood pressure. But then, as we said, if you have a validated equipment, it will be fantastic to get the home blood pressure. Now we come to the, please.
Now there are home blood pressures which are coming, where you have something like a timer. You keep it you connect the home blood pressure apparatus to your arm, keep it at 3 a.m. and sleep, and the apparatus measures the BP at 3 a.m. So even nocturnal BP you can get by home blood.
The artificial intelligence is doing wonders in every measurement of blood pressure. Now, Anup, you have a very important task now. See, the definitions of blood pressure values, and when will you say that this gentleman is a hypertensive? And that's one. And the next part is, what is the goal blood pressure? We've been all talking about the lower better concept. So, and the definition seems to be changing its goalpost over the years. So this is a very important issue, and Anup, please.
Since this would involve a lot of values, I'll take the liberty to use one or two PowerPoint to just explain. Yeah, next slide. So the task is definition and treatment goals of hypertension. So the first slide, then next one. Yeah, so this is the, can you minimize that? Sorry, thanks. So this is based on the American Heart Association, where they have defined what is normal BP, what is elevated BP, and they have categorized BP into stage 1 and stage 2. This is not very practical, but it is very important for all of us to know, just to categorize the treatment that we have to give to various individuals which who fall in each of these brackets. So simple things first, normal BP, systolic is less than 120 and diastolic is less than 80. Now, when the systolic alone comes between 120 to 129 and the diastolic is less than 80, it is termed as elevated blood pressure. And once the systolic crosses 130 and reaches up to between 130 to 139, or the diastolic comes between 80 to 89, it is stage 1. Stage 2 is 140 of systolic or more than 190 of diastolic. So one thing which I would want to kind of put your attention to is and or. So if a person has 120 systolic and the 90 diastolic, that becomes a stage 1. So the higher BP, where the bracket, the higher BP value will take the precedence, and we have to stage accordingly. That is one practical thing that we have to point out. And hypertensive crisis is systolic of higher than 180 and diastolic of more than 120. So basically there is normal BP, elevated BP, stage 1 and stage 2 hypertension, and accelerated hypertension. Now coming to the goals, there lies the definition. Now the goals of treatment. Now the goals of treatment, as Dr. Mohan sir told, has come down with each decade, the target BP that we are trying to achieve. One of the landmark trials that kind of gave a lot of value to what the goal that is set now was a SPRING trial that was published around 2017. So based on that, the goal of the target BP for the patient is less than 130/80 in most of the population that we are trying to treat, except, now what are the exceptions? Now, the exceptions is in old age. Now, what is old age? How do you prioritize or kind of put old age in different brackets? The American Heart Association has termed it more than 65 years, while the European Society of Cardiology has made it further divided into elderly and very old patients. So elderly are those between 65 to 79 years, and very old is more than 80 years. So they why they have categorized geriatric population further into two is to set two different goals for them. Now, the blood pressure target for more than 65 years is less than 130/80 according to American Heart Association. Again, driven by the findings of the SPRINT and the ACCORD trial. But if you look at the EAC guidelines, the blood pressure target is 130 to 139 systolic and diastolic of 70 to 79. So these are the target goals. So we've seen how do you define hypertension. And we have seen the target goals according to the age bracket that your patient lies in that we would want to achieve. Thank you.
Basically, as I said, we generally follow either the American or the European guideline, even though we have Indian guideline, International Society of Hypertension guideline, even WHO guideline. So whatever it is said, the Europeans and Americans differ only in the definitions. While the Americans say 130, 80, anything more than that is something which you have to be treating. The Europeans are a little more flexible. They say 140, 90. But the goal is same. You keep it less than 130, 80 and go further low if possible. With caution. If somebody is already on his blood pressure is 120, 80 on treatment, you don't need to stop the drugs. Continue to do that as long as he is doing well. So the definitions are a little different, but the goals, as Anup said rightly, are absolutely same, and except for the maybe in the elderly age. I mean, Sibu, there was a time when we had a blood pressure level for every disease, CAD, CKD, diabetes. No more, same way. This is Anup was mainly discussing about the adult population. So what about the pediatric population? Is there any difference? We don't come across them very often, but in the two extremes, Anup mentioned partly about the adult, the elderly. You can add on something if you want to, and the pediatric population.
I'll add on something to the elderly treatment. So as Sir said, previously we thought that elderly people should not be aggressively treated. Their BP are likely to be higher. But then studies have shown that bringing down the BP significantly produces a significant reduction in the events. So definitely they also should be treated aggressively. But then who are very old, as Anup said, more than 80 years of age, we should be a little cautious. Don't start two drugs together, start monotherapy. These persons are likely to be developing postural hypertension. So always look for postural hypertension also. Start slow. Initially target a value of less than 150. That is the recommendation given in ESC. Initially target a very old person, more than 80 years of age. Target less than 150. Then if they are tolerating, then probably you can bring it down further. They are prone for postural hypertension. So check postural BP fall probably every visit. And even though we discussed about ambulatory BP monitoring or home BP monitoring and office BP monitoring, all these guidelines are using office BP monitoring for the treatment targets. So always probably office BP monitoring is still important. Regarding young patients like children, their BP is basically not on the outcome data. That is, their BP measurement is basically on the normative data available. That is, what is the normal value for that age and that height. So there will be a chart where the BP as per the age, the height, and what is the 95th percentile, what is the 90th percentile, or what is the 99th percentile of the BP expected for that age and height. From the chart, you can decide, especially for children below 13 years of age. Children above 13 years of age can have a value of more than 120/80 is considered hypertension. And children below 13 years of age, you go based on the chart. So again, here it is very important to use the appropriate BP cuff because BP apparatus, because the child size can vary. So the BP cuff should be significant, important. And again, the child should not be very anxious. A child can be very anxious in a hospital environment. So that also you should take into consideration. And the recommendation is that above 3 years of age, you should check the BP for all children. And then if normal, probably we should check as probably every year or more frequently if there is a history of hypertension or renal disease or some urinary problems or coarctation or some congenital heart disease, you should check it more frequently. But then we should not ignore a possibility of hypertension in pediatric age.
Thank you, Subbu. You rightly said about that. All the definitions are absolutely based on the office blood pressure measurement because it's impossible to take the other parameters like Abpm. And as the values, as Uni has mentioned, the Abpm values are definitely different from the office blood pressure. I think that is clear. Now, it is guesstimated that India has about 240 million hypertensives. It's a guesstimate. We did a All India survey 2019. You remember that? You were the preventive council chair. Maybe 130,000 patient data, and found out that we have about 30.5% prevalence of hypertension. That will translate into something like 240 million hypertensives. But unfortunately, the awareness of hypertension, the treatment, those who are taking the treatment, and pitiably, the control of hypertension in our country is absolutely bad. So talk about that, Gabriel, which is one of the most important issues in our country.
Thank you, Mohan. I mean, this is a problem which has been worrying, should worry all the physicians, cardiologists, and any medical practitioner in India, because the prevalence of hypertension in the adults in India is around 28 to 30%. And it is similar world over. In US also it is 30%. In Europe also it's 30%. In Africa also is 30%. So all over the world, the prevalence of hypertension in the adult population is around 28 to 30%. The difference is in the control. In US, around 50 to 60% of people with high blood pressure, they are controlled. Their blood pressure is in the target level. But India is dismal, that 15 to 16% of patients with hypertension, that is, they are only controlled. The large 85% of people with high blood pressure, they are not controlled. So much so that in a large meta-analysis, which was done about 10 years ago, incorporating all the studies, or they have found that only in the urban area, only 2 out of 10 patients, their blood pressure is controlled. And the rural area, it is still bad. Only 1 patient out of 10, their blood pressure is controlled. And the awareness is also proportionately low. The treatment rate is also proportionately low. So that is a big challenge to the people practicing in India, because it's our fault. And we probably are not doing the job we are supposed to do, because if the people whom we are treating, their blood pressure is not controlled, I think it is a negative aspect for the contribution of the physicians in this country. Another problem which we have unearthed in our study, we did a study in 10 years ago, incorporating 3 districts in India, in Kerala, North District, North Kerala, Middle Kerala, and South Kerala. Mohan and myself and Dr. Krishnan, Dr. Venugopal, 6 of us were there. And we did in Thrissur, we selected Arumbur Panchayat and Venkatanga Panchayat, and in Thrissur town. And similarly in Calicut and in Trivandrum. And what we have, we published this in so many, we have 6 publications in the international journals. And the last publication was 2 months ago in the Frontiers in Cardiovascular Medicine. There, what we did was we looked at the prevalence of hypertension in the young people. So we had 5,150 patients altogether in this study. Out of that, around 1,200 patients were young people. That is, young we defined as 20 to 39-year-old. So, and when we looked at the blood pressure and we checked their blood pressure, their awareness, treatment, and control, and we had very, very surprising results. That's why the paper was accepted in a prominent journal. 11% of young people in Kerala, they have high blood pressure, 20 to 39, very young people, 11% have high blood pressure. And 33%, another 33% has pre-hypertension. Pre-hypertension defined as a blood pressure systolic blood pressure between 120 to 139 or diastolic blood pressure 80 to 89, and many of the criteria just mentioned, they also will be high blood pressure. So I mean 33% of our young men and women, they have pre-hypertension, and 11% of our young men and women have high blood pressure. That means that 44% has almost either pre-hypertension or high blood pressure. This is something which we never anticipated, and I think that is the truth. And the second point is this pre-hypertension and both hypertension and pre-hypertension were predominantly happening in men rather than in women. In fact, when we looked at the prevalence of hypertension in the young men and young women, we found that 3 times higher prevalence of hypertension in the young men than compared to young women. We did not know why this is happening, why women are protected, why men are having high blood pressure at this young age. Now, one reason was the high prevalence of smoking and alcohol among these young people. So that is one, because women, fortunately, they are not in Kerala, they are not taking much alcohol or resorting into smoking. So that could be one reason why young women are protected. We don't know still what is the reason, but still the point is that 44% of young men in Kerala, 20 to 39 years, either they have high blood pressure as defined by 140/90, or they have pre-hypertension as defined by 120 to 139, and there is 3 times more prevalence among young men than young women. And second point is the awareness, treatment, and control. The awareness, treatment, and control among, understandably, naturally, they were not aware that they have high blood pressure. Say we had 11% prevalence of hypertension, but hardly 25% of the young men were aware that they had high blood pressure. And the control rate was still worse. Only 12% of the young people were controlled. Their blood pressure was very controlled. So I think that is a huge gap which probably we are not paying sufficient attention. Fortunately, women had better control than men. People with obesity had better control than men. And people who checked their blood pressure at least once in the past year, they had better control than people who did not check. So there are lessons. Why women had better control? We realized that women actually had opportunities to reach a health system, a doctor, more frequently because of the pregnancy and all other related problems. So women reaches to a doctor more frequently. So that could be the one reason. That is what we said. That could be a reason why women had a better control of hypertension in the young age. The other one is obesity. Why the obesity, the blood pressure was better controlled among young people. And we realized that obese people are more aware about their blood pressure. So they are more likely to go to a doctor and seek help. So that must be the reason. And people who check the blood pressure at least once a year. So that is the point. We have the initiative of Dr. Joy and all the IMA. Opportunity to check the blood pressure frequently, wherever possible. Railway station. We did a BP campaign, Mohan, you remember that. And we did in the railway station, bus station, and the number of people, we had 150,000 patients all over India. I was the Prevalence Council chairman at that time. And we published in National Journal. So we did a press conference, and one of the press people said, why are you in US and Western countries, BP measurement is easily. You don't need to pay a doctor. You don't, if you want to get a BP checkup in Kerala, you have to go to a doctor and pay him 50 rupees. So how is it possible? That is what he asked. Why don't you make it available in the chemist shop? Why don't you available in the railway station all the time? Not a particular day. Not a particular day. What he's saying is, why don't we is available? Why can't IMA start a counter in the railway station or a transport station for a BP measurement, or every hospital clinic I have a BP, and I talked about this, and
We had in fact a meeting, if you remember.
Dr.
Joy.
Damodaran,
Govindamurthy, you remember?
Dr.
Know your number.
Dr. Damodaran Chavakar, Raja Hospital, he actually gave me a huge book saying that he has been doing it ever since this was discussed. So I think that we doctors are guilty. We are not doing our job. And our job is very simple, because I mean, only 1/5 or 1/8 or 1/9 of people are getting treated properly and controlled. And these people are dying. And the enormous amount of people, the national wastage. So I think it should be a priority area in the IMA and all of us to improve the awareness, treatment, and control of hyperpressure, not only all over the general population, but in particular the young adults, which we have highlighted in our paper. Thank you.
Yeah, Gaber has painted a very good picture, and all of us are also equally responsible for that. I mean, remember, a couple of years ago, before the advent of COVID, we actually wanted to have the Know Your Number program, and but then I think we can restart it. Whatever the opportunistic screening for hypertension is one of the best possible way that we can do, and every possibility of measuring.
Doctors are also guilty.
Yeah,
They
absolutely.
They don't know the new numbers, new values which doctors you have pointed out. Must be surprised to most of you. And you must leave. I actually personally, I went around in 1990 to the UK 160 and 90, and I thought it was normal. So I think this is an area where we need to have.
Absolutely. I mean, 1990 it was okay. You remember the great president, American president Roosevelt? Roosevelt's blood pressure in 1945 Yalta conference. Now it is the war from Ukraine. Yalta was in Crimea. Was 190 over 130. And his physician, Admiral McIntyre, he was an ENT surgeon, but he was an admiral. He was a personal physician of the American president. Everybody at that time thought that 190, 130. Forget about it. Poor fellow died within another. Of course, that comes to the importance of treating blood pressure. We have now a goal, definite goal, and we have drugs from at least from 1950s. Till that time, we have hardly anything, but from the advent of diuretics, and then we have at least 17, 18, 19, 20 formulations of the drug only. Now, so what are the general, it is not possible to talk extensively about the treatment, the general principles of treatment of hypertension, what is the importance of a combination therapy? Yeah, please.
One point is that when we look at the goals, new goals, you look at the spring trial. If I remember correct, the spring trial, they had meticulous BP measurement pattern, and at least 50% of the people were evaluated in a automated BP alone. There was nobody in the room. Even 50%, nobody in the room, quiet, nobody to speak with, they were quiet, and such a meticulous measurement was taken for this low target. But if you look at your mobile, or if you read something, your BP can go up by around 10 to 15. So that also we should take into consideration before extrapolating these guidelines.
But even accepting that,
we are talking about even 140, 90.
No, keep less than 140, 90. Bring it down to 130, 80. Bring it further, if possible, down. That's all we are saying.
So, sir, my point is that we should not, when we are checking BP, we should be doing it properly. That's all.
absolutely.
No questions.
In fact, the chair of the ACC 17 guideline was asked when he was presenting the ACC guideline, when press representative asked him, how is it possible? This will take 10 minutes to check the blood pressure. So how do you think that an average physician is going to check blood pressure like this? He answered, if you are going in a flight and the pilot says, I am very busy today, so I will cut some corners. I will not do this, that, and I will fly. Will you go in that flight? Or you go to a laboratory, check your blood sugar, and the lab man says, I am very busy today, there are 101 patients. So I will just cut some corners and get the lab value. Are you going to go to that lab and check your blood sugar? And more people die of uncontrolled hypertension than people dying in a flight or people dying because of wrong lab values. That was his answer. So if you're not able to check the blood pressure properly, you should not check the blood pressure. You should say, I can see only 10 patients today, if that is what you want. So that is the answer. That was, of course, by the way. Okay, my topic Mohan asked was regarding drug therapy and combination. Well, you know, hypertension is known as a silent killer. Most of the patients are totally asymptomatic and they are detected like in the railway station, or maybe they go for some other reason to the hospital. So why do you want to treat hypertension? You want to treat hypertension to reduce events, whether it is myocardial infarction or stroke or heart failure or renal failure. So first point is that when you start treating a patient, you should use a drug that has been shown to prevent events. There is no point in just giving a drug which reduces the blood pressure. You should have data to show that this drug reduces events. So right now, these are the 4 drugs that we have, which have shown to reduce events. They are ACEI, ARB, calcium channel blocker, and diuretics. So all guidelines across the world say now you start treatment with one of these 4 drugs. Beta blocker was there earlier, but slowly beta blocker has gone out because now there are trials to show that beta blocker actually does not reduce events. So beta blocker can be given in specific situations like heart failure or post-myocardial infarction, but in general, beta blocker is not now considered a first-line drug. So these 4 drugs are the first-line drugs. The second thing you have to think about is that, again, as I said, you are going to a totally asymptomatic patient. And the biggest problem of treatment of hypertension, as we have seen, is lack of compliance. So you should give a drug which has the least side effect profile. Otherwise, the patient is not going to take it. Now, all these drugs have some minor side effect profile, but the drug with the least side effect profile is ARB. That is why most people say that ARBs can possibly be given as a first line of drug if cost is not a constraint, because it does not. If you give drugs to patients and follow them up 5 years, there is data to show that more people on ARB continue taking their drugs than people who have been given a placebo. So ARBs are that placebo-like side effects. So maybe the first drug should be ARB. But again, of course, you can decide what you want to give. But one exception will be the elderly with isolated systolic hypertension. In those patients, the current recommendation is you give either a calcium channel blocker like Ambulatory or you give a diuretic. So in elderly, the drugs of choice are calcium channel blocker or diuretic, whereas in the others, you can give any 4 of these drugs as first-line drug. Now, if you give a single drug, if you start, earlier it was a step care approach. You give one drug, go it to the maximum dose, the blood pressure is not controlled, you stop it, put him on another drug and repeat the story, and then you give a combination. By the end of the day, the patient gets frustrated, the doctor gets frustrated, and the patient goes off without any drug. So that is not possible. You have to control the blood pressure at the earliest. And that is why now most people believe that you should start with a combination in the vast majority. Trials also have shown that most people finally at the end of the day require combination. So why not start with a combination? If you give a single drug, whatever these 4 drugs or even beta blockers, on an average, only about 35 to 40% respond to one drug. So if you give a drug, it is likely that 65% of patients will not be responding to this drug. And as you increase the dose of the drug, as you double the dose of the drug, the blood pressure reduction also does not go to double. It will be only maybe 150%. It will not go to 200%. So in all ways, it is possibly better, whereas the side effects will become double. So it is always better to start a combination drug, maybe in a small dose, so that the side effects are less and you get the BP under control at the earliest, and so it improves the compliance also. Now, among the combinations, and another thing with respect to single drug is that, hypertension is a multifactorial disease. Several factors are at work. So if you give one drug which controls one factor, the other factors will be stimulated and the counter-regulatory response comes and the blood pressure goes up again. That is why the response to a single drug is only 35 or 40%. So all this tells us now that most of the patients, vast majority, will require a combination treatment. Now, among the combinations, again, if you go by data, the best combination is a RAS blocker with a calcium channel blocker, either an ACEI or an ARB with a calcium channel blocker is the best drug. The second best will be an ACA or ARB with a diuretic. Now, if with the combination, the blood pressure is not controlled, you give the three together, ACA or ARB, don't combine ACI and ARB. It is not recommended. ACA or ARB, calcium channel blocker and diuretic. That will be the third combination. If it is still not controlled, the next best drug is probably spironolactone, the mineralocorticoid receptor antagonist. So that is how it goes. ACA or ARB plus calcium channel blocker, then add a diuretic, then add a mineralocorticoid receptor antagonist, that is spironolactone. Then, of course, you can go to beta blocker, alpha blocker, and all the other groups of drugs. But then, of course, there are specific situations, like say in a patient with myocardial infarction, beta blockers are number one drugs. And you should also, most of them will also be on a RAS blocker. Patient with heart failure, you have the foundation drug, quadruple therapy, beta blocker, RAS blocker, mineralocorticoid receptor antagonist, and now SGLT2 inhibitors also. So it varies from the compelling indication. What I have been talking about is only in general. ACE or ARB plus calcium channel blocker plus diuretic plus spironolactone. I think I'll stop here with that.
Thank you, Nee. That gives us the general principles of management of hypertension. And as Nee rightly said, let us individualize it, but these are the general principles. Basically, the earlier days, our ICUs were full more of myocardial infarctions. Now, maybe more than 50% of our ICUs are occupied by heart failure patients. Hypertension is very much closely associated with heart failure. They are close cousins, Tweedledum, Tweedledee. Anup is very much special interest in heart failure. Anup, you can throw some lights on hypertension and heart failure.
Again, I'll go back to my slides just to make my point a bit more clear. Slide number 5, please. So, as Dr. Mohan was saying, hypertension is a silent killer. Why? Because if undetected or if it is not optimally controlled over a period of years or decades, it affects all the organs of the body, from the eyes, the nerves, the kidneys, and obviously the heart. And one of the most common manifestations of uncontrolled hypertension is overt heart failure. Now, what are the, sorry for this slide, I think what are the mechanisms of heart failure in hypertension? Now, the most common way or the most common mode in which heart failure develops is due to diastolic dysfunction, which was the commonly used term, and the current way in which the cardiologist at least term it is heart failure with preserved ejection fraction. Now, let us see how it happens, the sequence of events. In hypertension, there is an increase in afterload. Afterload is the pressure that the ventricle has to overcome in order to push the blood out of the ventricle into the great arteries. So in hypertension, there is an increase in afterload. So the increased afterload over a period of years or decades will result in left ventricular hypertrophy by Laplace's law, wherein in order to reduce the tension, there will be increase in thickness of the left ventricle. Now, this increase in left ventricular thickness or the left ventricular hypertrophy will result in decreased amount of volume in the left ventricle, or the filling pressures increases. As the filling pressures increases, then the diastolic dysfunction sets in, and that is known as the heart failure with preserved ejection fraction. So this pressure increases even before the left ventricular hypertrophy sets in. So the hypertension and heart failure, there are basically they've graded this into grade 1, 2, 3, 4. Sorry for this slide again. I don't think it has come properly. So this grade 1 is LV diastolic dysfunction or HFpEF even without LV hypertrophy. Stage or grade 2 is LV diastolic dysfunction with LV hypertrophy. Stage 3 is like a stage C in heart failure, symptomatic heart failure with preserved ejection fraction. Heart contractility is normal, but the patient has dyspnea on walking, has pedal edema, and clinically would come to you as a heart failure patient, but the heart pumping is normal, but has left ventricular hypertrophy and increased filling pressures on echocardiogram with increased JVP and edema, and maybe find by basal crackles on examination. And stage 4 is those with a large, with a dilated left ventricle. What happens is that when there is an increase in afterload and increased volume overload over a period of time, there is an eccentric remodeling also that sets in. Left ventricular hypertrophy is concentric remodeling. When there is a volume overload, eccentric remodeling sets in, and that increases the LV cavity dimensions. And that is when the heart pumping comes down and heart failure with reduced ejection fraction sets in. So to kind of give you an overview, how hypertension leads to heart failure. One is heart failure with preserved ejection fraction, as I told now. Second is heart failure with reduced ejection fraction, where the heart pumping comes down. Third is cardiorenal syndrome, where hypertension is not only affects the heart, it affects the kidneys as well. And there are cardiorenal syndrome again is divided into 4 types. One of the most common manifestations is acute pulmonary edema due to bilateral renal artery stenosis, as we have all learned in our MBBS and MD. And one of the common association, which is often realized, is the association of obstructive sleep apnea. So you get a hypertensive young patient who is obese with increased neck circumference. Obviously, one of the questions that you have to ask, not the patient, but the bystander, is about the snoring habits in the night. Ask about whether the snoring is heard loud and clear in another room. Ask whether there is abrupt stoppage of breathing in between. Ask whether there is daytime somnolence. Ask how fresh he feels when he gets up in the morning. All these will give you clues about the presence of obstructive sleep apnea, which is a treatable cause now with sleep study and a CPAP machine. So obstructive sleep apnea is often associated with heart failure with preserved ejection fraction. And this is something as physicians we should not miss, and we should have a high index of suspicion when we see a hypertensive who is obese with increased neck circumference and hypothyroid and arrhythmia. So when hypertension with left ventricular hypertrophy, when the heart, the filling pressures are high, there will be some amount of left atrial dilatation. And this is a substrate for atrial arrhythmias. And if these atrial arrhythmias are undetected or uncontrolled, then all these can lead to tachycardiomyopathies. And this is another not so common, a rare manifestation of heart failure. And this is one of the ways in which hypertension causes heart failure. Thank you.
Thank you. The importance of heart failure is that preventing and treating hypertension can prevent the development of heart failure. We are coming to the last few questions, don't worry. So that comes to the importance of hypertensive urgencies. You can have emergencies and urgencies. Somebody can come with a hypertensive crisis. It could be an urgency where there is no target organ damage, or an emergency. And again, I want to need to give the because there are very many clinical scenarios, and it is the time will not permit us to go to the extensively on that, but then the general principles of management of hypertensive crisis.
Now, hypertensive crisis by definition is when the blood pressure is more than 180 over 120. Now, it is in general divided into hypertensive emergency and hypertensive urgency. But before that, one has to make sure that the BP is 180 or 120. That is called reactive hypertension. That is the commonest mistake. Patient has a headache and the blood pressure is 180 or 120. So here the headache is not due to hypertension. In fact, the high blood pressure is due to the headache. Patient is worried about his headache and the blood pressure goes up. Similarly, very commonly, patient has got a vertigo, classical vertigo. But because of the vertigo, his blood pressure goes up, and it is said that the vertigo is due to hypertension. It is not like that. So that is reactive hypertension. So first thing is to make sure that it is not a reactive hypertension. Then you divide it into hypertensive emergency and hypertensive urgency. Hypertensive emergency is that situation where you have the BP and some impending target organ damage. The target organ damage can be in the brain, when it can be stroke or hypertensive encephalopathy, or an intracerebral bleed, intracranial bleed, or it can be in the heart like a myocardial infarction or a heart failure, or it can be vessels like a dissection of aorta, or it can be in the kidney like an acute renal failure. So if any of these things are there, that is called a hypertensive emergency. Whereas if none of these things are there, just the BP high, it is called hypertensive urgency. Now, what one has to understand is that there is nothing urgent about hypertensive urgency. And so the name is now no more used. It is called asymptomatic uncontrolled hypertension, because these patients, if you hospitalize them, it has been found that there is no benefit. So these patients need not be hospitalized. They can be treated in an ambulant manner. And the commonest reason for hypertensive urgency is because the patient has stopped the drug. So you restart the drug, or if the patient is already on the drug, you change the combination and you can send him home. So hypertensive urgency or asymptomatic uncontrolled hypertension need not be hospitalized. They can go home. On the other hand, hypertensive emergencies require control of blood pressure with a parenteral drug in an ICU. So they have to be in an intensive care unit. They have to be on an IV drug, and you have to monitor the three important organs: heart, brain, and kidney. Heart by the blood pressure as well as the heart rate, brain by the level of consciousness, and kidney by the output. All these things you have to see. The general principle is that you should not bring down the blood pressure very fast, because if you bring down the blood pressure very fast, that will affect the perfusion. After all, there is some auto-regulation. You have to give the time for the vessels for auto-regulation. So don't bring down the blood pressure very fast. On an average, you can say bring down the BP by about 15 to 20% in the first hour. And by the end of the day, by next day, 24 hours, it can be about 160/100, and then bring it down to normal levels by third or fourth. That is in general. There are three situations where you should bring down the BP very fast. One is dissection of aorta, where you have to bring it down to 120/80 at the earliest. Second is eclampsia, pregnancy-related blood pressure, where also you have to bring it down fast. And the third is pheochromocytoma crisis, where again you have to bring down the blood pressure fast. And there is one situation where you don't bring down the blood pressure except in the extreme, that is stroke. In stroke, you are not supposed to do anything unless the BP is over 220/120. If it is only more than 220/120, you do anything. And there again, one exception is there if you are planning thrombolysis. Even if you are planning thrombolysis, don't bring it down below 185, because if you bring it down to below 185, there will be hypoperfusion in the brain. So dissection of aorta, eclampsia, and pheochromocytoma, bring it down fast. Stroke, don't bring it down at all, or bring it down very, very slowly. And in the rest of the situations, you can bring it down by 15% or 20% in the first hour. By the end of the day, 24 hours, bring it down to around, say, 160/100. And by 2 or 3 days, bring it down to normal levels. That is what the consensus presently is.
Thank you, Unni. So urgencies take days or weeks, emergencies hours or early days. Okay, that's the principle. Now, Anup, I'm coming back to you, because Unni mentioned about, you also mentioned about the kidney disease, and the hypertension is the cause and the effect of kidney disease. And we have problems of, and mind you, hypertension itself causes vascular disease. CKD again is another considered to be a coronary artery equivalent. So you have a double whammy. So how are we going to manage? And also people's apprehension about use of, Unni was mentioning about the importance of ACE, ARB. And always there is a confusion in the minds of the people when you should be not starting these important drugs.
As Mohan sir just now told, hypertension is the cause and effect of CKD. And as physicians, I think that one of the most important things that we have to keep in mind is that the single intervention, if somebody asks you, which is a single intervention which can reduce the progression of CKD, that is optimal BP control. Again, the single intervention, if somebody asks you, that can reduce the progression of worsening renal failure is optimal BP control. That has to be ingrained in all our minds. And that lays the premise for the next part is hypertension and CKD management. I think, again, sorry for the slide. So basically the mechanism of hypertension and CKD is increased sympathetic tone, increased salt sensitivity, upregulation of renin aldosterone activating system, endothelial dysfunction, and increased arterial stiffness. So there is a substrate for hypertension in these patients. So when we manage, as we all know, management of hypertension in CKD is quite challenging because few of them have resistant hypertension, and it takes polypharmacy to control BP in these patients. But again, what we have to keep in mind while educating the patients is the importance of lifestyle and diet. Tell them to shed that extra weight, tell them to reduce salt in the diet, tell them to have aerobic exercises amounting to 90 to 120 minutes a week. All these set a good foundation for the polypharmacy to act. Studies have shown that if you lose 5 kg, then you can bring down your systolic BP by 5 millimeter mercury. You reduce daily salt intake to less than 1.5 gram, you can further reduce your systolic BP to again 5 millimeter of mercury. So the bottom line or the foundation is the lifestyle and diet. Now, what medications to choose? Now, while trying to understand that question, what we have to know is that ACE inhibitors or ARBs will cause efferent arteriolar dilatation, will decrease the intraglomerular pressure, and will decrease proteinuria. So this is a fact. So the first and the foremost drugs that we have to give a diabetic nephropathy patient is ACE inhibitors or ARB, provided there are no contraindications. We all know what it is, and we all know how to monitor a patient on ACE inhibitor ARB as well. This is followed by a calcium channel blocker, a diuretic, centrally alpha blockers, and last beta blocker. These are the sequence of events, the medication that we follow. The question that we have to answer before that is whether the patient has proteinuria or no proteinuria. Now, whatever agents that we use, the target that we are trying to achieve is a BP of less than 130/80. We have multiple CKD patients going on with 170, 110, 170, 100 on polypharmacy, with an adequate scope for improving the dose of these individual hypertensive medications. That should not happen. We should have a low threshold to use polypharmacy. We should have a low threshold in uptitrating the dose to guideline recommended levels in order to get a target BP of less than 130/80. This should be synergized with lifestyle and diet modifications. Thank you.
CKD hypertension is always difficult to treat hypertensions, and as Anup said, you have to use multiple drugs. One of the easy ways is you divide them into a proteinuric CKD, where invariably you have to use ACE, ARB plus the other drugs. If it is a non-proteinuric CKD, then you can choose any of those drugs. There are no compulsions to use ACE, ARB as the number one. That was one of the KDIGO suggestions. But then coming to the last couple of questions, okay? I can smell some gastric rumblings, not yet. Sibu, Joy has been very aggressive in the exercise. Every Sunday we have Zumba. And so exercise has been an absolutely important part in hypertension. You are also an exercise freak. So tell me about the importance of exercise.
I'm not an exercise freak. I want to do it, but then, okay. As Anup said, physical activity and lifestyle modification is very important. A drug can reduce the BP by around 5 to 10 millimeters of mercury. So lifestyle modification is as important. It can reduce a regular physical activity can reduce the BP, systolic BP by around 5 or 10 millimeters of mercury. So lack of physical activity is a risk factor for coronary artery disease, is a risk factor for hypertension, diabetes, obesity, all those things. So regular physical activity controls all these things. So it produces multiple effects: reduction of weight, control of blood sugar, reduction in the lipid levels, and also a control of the BP. So a moderate or higher intensity aerobic exercise of around 30 minutes per day for almost 5 days a week or even 7 days a week is recommended. So that is around 150 minutes of aerobic activity per week is recommended. And 2 or 3 days you can have resistance exercise or high intensity interval exercise also. So we can start with that. And if the person is accustomed to this type of exercise, it is good to have even higher levels of exercise. Even higher intensity exercise reduces the BP much better. So even can go to 300 minutes of aerobic exercise per week. So a regular exercise. So at the time of exercise, the BP will go up. But after the exercise, the BP remains low for about 24 hours. So if you do not do it regularly, if you do it only once a day, the effect is not there. So you have to do it every day for the effect to be sustainable. And it produces a decrease in the peripheral resistance. It produces the better remodeling of the heart, the hypertrophy, all those things, it becomes better. So regular exercise should be encouraged in all persons.
There was some apprehension for the hypertensive groups about the resistance training. But then is it an apprehension only, or you can very well do it?
You can very well do it, and actually a few studies have shown that resistance training is actually better in bringing down the BP compared to the aerobic exercise. So resistance exercise at least 2 to 3 days per week is very good and should be done. It is recommended.
Thank you. So before we break for dinner, I am going to ask Giver about what is the ideal diet. Not that you should follow what he says for today, but that is up to you. But then,
we all know that. I think as a physician, as a doctor, this is the most frequently asked question to a doctor. And the most commonly ignored answer also is about diet. Because I spend a lot of my time, and I am sure that all of you must be spending a lot of time advising patients about diet. And the patient never forget to ask you, so what is the diet I should take? They will ask you, but you can be sure that they will not abide by whatever you say. So I have always felt that the most wasteful time in my practice is advice on a diet. And I think that must be the experience of all of you. But barring all this, we all know that salt restriction reduce blood pressure. And it's reduce blood pressure more in people with high blood pressure than a normal person. So salt reduction is important. How much reduction should be advised? The problem is very complicated, because many people say that very low sodium restriction to less than 1,500 milligram of sodium, that is into 2.5 is the sodium chloride. So less than 1 teaspoon of sodium, but sodium chloride. But I think that is everybody agrees that these kind of advices are not practical. So more practical will be probably to recommend a sodium intake of around 3,000 milligram. That will be around 7.5 gram of sodium chloride. So sodium chloride, I think practically we can ask them to avoid all the salt-rich food, specifically name them like papad, achar, pickles, salty fish, chips, and all those things. And that is how to go about it. And also to stop adding salt while cooking. And also in Thrissur, there's a practice of adding salt when rice is boiled. I think it's still prevalent. So this practice is definitely going to raise the blood pressure. So we should advise strongly. The other point which has emerged recently is the ratio between the sodium intake and potassium intake. Now, if whatever ill effects of sodium intake can be countered if you can increase the potassium intake. So if you suppose you are a foodie and likes a good salt and all, it is all right still if you can use high potassium diet. So some of the salts are, you get potassium replacement salts are available, like rock salts which are rich in potassium, or better still will be fruits contain a very high amount of potassium. So also vegetables. And if the creatinine levels are normal, you should be careful. Otherwise, the potassium, you can allocate liberal amount of potassium to a hypertensive patient, and you are sure that even if he takes slightly more salt, his blood pressure will get controlled. Another important point, as I've been already highlighted, is the reduction in the weight. As Dr. Sibu said, or Anoop also said, 1 kg weight loss will bring down the blood pressure by 1 millimeter. So if you can reduce your weight by 10 kilogram, then you can reduce the blood pressure to a significant extent of 10 millimeter mercury. That is reduction in blood pressure.
And then there is a big trial that is called the dietary advice to stop hypertension. That is called the DASH diet. So that DASH diet is now very popular, but it is simple what we have been already advocating. The DASH diet consists of lots of vegetables, lots of fruits, then unpolished rice or wheat, then the legumes, the pulses and all, a large amount. Then poultry, that is all right. Avoid red meat, avoid all the bakery foods, avoid trans fat, and then you probably get a good control of blood pressure. So this is a standard diet for advice for a very purpose to prevent heart disease also. So you can stick to the diet which has been proved to be heart healthy by recommending a lot of vegetables, a lot of fruits, a lot of pulses, a lot of and nuts are okay, and lots of unpolished rice and unpolished wheat. So that I think summarizes the dietary advice.
As Givasa said, this is the most difficult part, the dietary advice. So what I think is that to change a person's diet, which he was used to till that period, it is very difficult. So there are so many things you can advise, but then probably you can start one change per month. Then once the person is accustomed to that, probably we can implement that. That is the way, I mean, we have been advising dietary changes, but it is not getting implemented. So probably salt restriction first, then something later, add-on and add-ons like that, probably we can try.
Now, one thing we have always felt is, that is I always written and highlighted this. We doctors always say, no, don't do that, don't take alcohol, don't take salt, don't. So these no's are probably people don't like. So instead you take yes. Don't talk about no's. Talk about you take fruits, you take vegetables, you take pulses, you take fish. So concentrate on yeses rather than no's.
So on that nose and yes, we are about to stop it. I don't think you have the inclinations to ask any question. You're welcome to do that. But otherwise, I thank all of my, especially Anup. Please, you're welcome. You want to take that? Statins and hypertension.
There is no direct role for control of hypertension with statins, but when a patient is having hypertension and if he is having a dyslipidemia also, then the risk is more. So a patient, you have to assess the person's risk. So not only hypertension, that person's cardiovascular risk can be assessed. There are so many scoring systems. And then if the person's risk is high, we should be on statin.
This factor adds on to your. So if you remember, just to there were two factors. We must mention about the hope factor and 25 on target. On target shows better result. When somebody said that because you feel 20% of hope trial and 60% of on target, that is, I mean, one of the big debates. So statins are definitely going to help him because we know most of these hypertension has. If you calculate the risk score, it will become higher.
They have got other associated metabolic syndrome or other problems.
No. The answer to your question is statins they don't lower blood pressure. If that is the question. They don't lower.
X can be taken in a moderate quantity. They are actually good, healthy food. But then when taken in, probably 3x per week are recommended.
I am a strong proponent of encouraging people to take whole egg, including egg yolk, mainly because the previous strict criteria advice not to take egg was based upon the thinking that the eggs are yellow is rich in cholesterol. So if you take more cholesterol in the diet,
your cholesterol level will go up proportionately. But people later found that it is the saturated fat, like if saturated fat in the beef or in your trans fat, or that increases the cholesterol much more than the egg yolk. And it's a very cheap source of protein. And without the yolk, eggs are not very tasty. So I recommend, now I have written also, 1 egg per day is all right for even patients with heart disease, even though the recommendation guidelines say 3 eggs per week. But the problem is, even if you take 1 egg yolk per day, every day, the increase in cholesterol is only 3 milligram or 4 milligram. But you also get an increase in HDL cholesterol. So in the bargain, and since in India, where already we are protein malnourished, I think this is a cheap source. The price of eggs have not gone up for the past 20 years. So I think we should start recommending, continue to.
Importance of dietary cholesterol.
I used to argue for this in our meetings also. And probably we have seen our cardiology meetings, where doctors and cardiology physicians ordering egg white omelette. At the same time, after lunch, the sumptuous the desserts and all those things that made the W.C. Roberts, is the editor of American College of Cardiology. He visited India. He was a strong proponent of the statins and lipid lowering for treatment of heart disease. He wrote an editorial that I visited India, and then I was wondering, India is largely a vegetarian country, and why the heart disease is going up. And then I found out the answer when I attended the conference, when people were gulping quantities of ice cream and desserts and all. I realized the answer to our is because our dietary indiscretions.
Actually, we have to do it properly. Otherwise, but then we can get an idea. Suppose a person is having a very high BP. So we can ask, suppose that person is having high BP, you can ask the person to rest and check the BP. Suppose you screen 100 people and 50 people are normal, or 70 people are normal, you can leave them. So those persons who are very high BP, you can pick up those persons. So this opportunity screening, or this screening is very important to pick up very high BP. So those very high BP persons, you can ask them sit for 5 minutes and then we can check again. So every person you cannot do that. Then
in the United States, every barbershop had a business.
So we can try to modify.
It is still very useful. Very useful, because if you have a casual BP, 150 by what we are advising them is not to straight away go to take medicine. We are asking them to check the blood pressure properly with a doctor, and then if it's found to be high, so we are not panicking. We are causing panic to the patient. But I think yes. In young ladies, yes, that has been discussed. So that people have analyzed this, and people have, there is a studies, the same phenomenon about young women and young men is reported by all the literature from US and Europe also. So same phenomenon. So mostly this is probably due to the hormonal protection. But in Kerala is a unique situation where men only smoke and men only usually take alcohol. So that also, alcohol is well known to increase hypertension. So we don't know the proportion and the ratio of each component contributing to hypertension.
So we will have the last one. no more number of
WHO recommended it. There are other equally good. There are
good BPA parasiting well-shallow or something where they have got a system. Once you connect it, it will automatically take 3 readings. It will wait for some time, take the first reading, then after 1 minute it will take second reading, and after another minute it will take third reading, and then average and give you the reading.
all the 3 or the last?
Average the last 2, well-shallow. So there are different companies which are bringing out such machines which can make the BP measurement better.
smaller
No, adult hypertension hardly ever produces symptoms. Even if BP is 180 or 120, it will not produce headache. So it is very, so same thing is with epistaxis. Hypertension hardly ever produces epistaxis. Well, what you can do is to give him a paracetamol and check the blood pressure after half an hour, it will come down. Or maybe just reassure him that nothing is wrong and check the blood pressure again, it will come down. That is the best way. In general, it is the other way around. Hypertension producing headache rather than hypertension, vertigo, nosebleed. These are the 3 common culprits of reactive hypertension.
Thank you, my panelists, and thank you, IMA, for the opportunity. Good night.